So what we have coming up is a presentation by Maura Proser, a COVID update, and then we will move to the final closure remarks. So,
do we formally have to table that, Paya? Excuse me. Do we formally have to table the with a motion or not? Okay.
Yes, we do formally have to. So I think we're good, Renee. Are we not?
I think we also need a motion to return from executive session.
Yes, we do.
Okay. So are we? Sorry. Is the motion to move out of executive session? Okay. Fine. Thank you. Do we have a motion to move out of executive session?
So moved.
Yes.
Thank you. And second, was that Julie Schills? Great. Thank you. All in favor? Aye.
Aye.
Anybody opposed? Thank you. Motion carries. We are now at an executive session. Dr. Faywell, did you have a comment or were you moving?
No.
Good. Okay, great. All right. So as a first action item, I would like to have a motion to table the election of the Board of Health officers for 2022 until the proposed bylaw changes can be discussed and potentially approved. Is there a motion to table the election of the officers?
So moved.
Is there a second?
Second.
Thank you. All in favor, say aye.
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 Anyone opposed? Great. The motion carries. We have now tabled the election of the Board of Health officers. The next and last item is to discuss the tentative meeting schedule for 2022. In the current year, we've been meeting every month on the second Thursday, and our proposal for next year for 2022 is to continue that schedule. Last year, we did say that if there were any meetings that we chose, that we decided we didn't need to have, we would cancel that meeting. We didn't have to meet every month, but as it turned out, we had plenty to talk about. We did meet every month. So I'd like to have a motion to approve the proposal that the Board of Health meet monthly in 2022 on the second Thursday of every month.
So moved.
Second.
All in favor, say aye.
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 Anybody opposed? Okay, thank you. The motion carries up. I assume there was, I skipped the discussion part, but I think we've been in discussion and just recognized that that schedule is a tentative framework, and we can always add in topics as we go through the year and focus on any of the priority issues that are really important to the Board of Health. So,
And just to clarify for the minutes, we'll continue meeting at 4:30 p.m., correct?
yes. Yes.
Yeah, I have a question about Zoom.
Okay. Go for it, Rosanna.
I just want to ensure we're continuing to meet by Zoom.
Well, we did consider meeting in person. We took a poll at the time that we did the poll. The majority of people were still wanted to meet virtually. This is certainly a topic that can be reconsidered on a regular basis. I mean, it's my hope that in 2022 that in-person meetings will be something that we all feel comfortable being a part of. It's just a topic that we will continue to look at. Okay.
I'm nodding. Sorry, you couldn't see me.
Okay, great. So as our first information item, Maura Proser, and thank you for your patience. You will provide an update on substance abuse and overdose prevention efforts within Tri-County Health Department. Maura, welcome.
For having me back. I'm gonna, share my slides. So thank you again, board, for having me back. I'm Maura Proser. I am a manager in the CHP division. And I'm going to provide just a little bit of an update around substance use prevention and the overdose prevention work that we're doing. And I hope I can answer any questions. And I will also look to Penny. I know Lauren Mitchell had to attend another meeting, so I'm hoping Penny can also help us answer some questions, as we really have two kind of big chunks of the work we do related to substance use and overdose is really we do a lot of primary prevention work. We do community-based work focused on partnerships and treatment access. And then we also have, as you know, and you received an update in September, the syringe access program, which is very much tied into the work that we do. So I think this is, I'm not going to read all of these to you, but we know that the overdose epidemic has been in the headlines. It was in the headlines years ago, and it unfortunately continues to be. And in the last 2 years, we have seen fatal drug overdoses increasing greatly. In March, we saw a headline about a 59% increase. We know that fentanyl is a big component of the increase in deaths. And then very sadly, very recently, we just started seeing headlines that we have now, for the first time in the United States, hit 100,000 deaths in a year across the nation. And the one thing to notice with this is that this is not cumulative. This isn't how many people we lost this year, add this year. This is how many people are dying. And please remember that each one of these is a person, a brother, a son, a sister. So it's really important to us to be thinking about how we can take our work to really be helping families and saving families. So these are the data that we have, and I believe you have seen these data as well. I think Lauren shared them when she presented in September. The 2021 data are provisional and they're not complete. Obviously, we're still in 2021, but we do have some provisional data. You know, we cannot conclude, oh, it was just a blip in 2020, everything's getting better, but we are hopeful to see that perhaps some of the work that we have done is starting to bring mortality down again. But, you know, we know that we hit a spike in 2020 and that, you know, in some areas, we're still seeing way too high mortality related to drug overdoses. And these data here are for all substances. You know, one thing I will say, when we look at these data, all we can say are a statement about the data. This is what the data say. These are the actual numbers. We can't draw any conclusions. We can't say why. We can't say what happened, what caused this. So, you know, I know a lot of us have seen headlines rushing to say this is because of the pandemic. And I think there may be some evidence that the pandemic didn't help, but I'm uncomfortable making the conclusion this is just because of the pandemic. We did look at data month by month in 2020. And unfortunately, we were seeing elevated death rates even in January and February of 2020. So these here are pharmaceutical opioids. And again, we see increases here. And unfortunately, in Adams County, we're not yet seeing that decrease that we're starting to see. Perhaps we're coming down in the other counties. And this is heroin. And what we are seeing is actually that deaths, with heroin involvement are going down. So as much as I'd like to say this is a high point, we are seeing a reduction in deaths due to heroin. Unfortunately, we really are seeing fentanyl just coming into our community and being responsible for a huge portion of the increase of deaths. Unfortunately, we are not seeing numbers come down due to fentanyl, and we're just seeing them go up. These data do not include the 2021 provisional data, but you know, when we look at these maps every year, they're pretty much, we're keeping the red spots pretty much in the same area. So we're seeing Southwest Adams County, as well as kind of Central and North Aurora as our hotspots. And the most useful thing with these maps is these maps are how we plan our street outreach, the work that our syringe access services does. And these are the communities that they're in. They're really working in the Aurora community as well as Southwest Adams County. This is the framework that we utilize to really think about substance use prevention as a continuum. So we need to prevent early usage. We want to prevent young people from ever experimenting and ever becoming addicted. We also want to make sure that we are helping those who already are addicted. We're getting them treatment, we're supporting recovery, and we're thinking really that full continuum, people who aren't ready yet to get treatment, we're focused on harm reduction. So this is the continuum that we focus on in the framework that we use. We're very focused on the idea that this needs to be a comprehensive approach. This is a very complex issue. We can't just look at one thing. There is no one thing that will solve this issue. We also want to make sure that we have equity really incorporated throughout all of the work that we do. And then, of course, through our data and evaluation, we have a great data team who really does some great surveillance to help us track the work we're doing. So just a quick overview of some of the efforts. For youth prevention, we really try to take everything that our team does is using a shared risk and protective factor approach. So the understanding that the same risk factors, the things that make you more likely to engage in a behavior, and the same protective factors, the things in your community or your family that will protect you from engaging in risky behaviors, they are very much the same for substance use, for violence, for suicide. And so we really try to take all of our work and combine our work together. So including our tobacco grant work, as well as our youth substance use prevention work, as well as a strong partnership with our youth bullying and suicide prevention work, really looking across at shared risk and protective factors. We do have 3 community coalitions that are funded very specifically by substance use prevention funds. And they are all competitive grants. So the Douglas County Healthy Youth Coalition is a partnership we have with the Douglas County School District. The I-70 Corridor Communities That Care Coalition is a partnership with the Bennett Parks and Rec District. And then the Aurora Partners for Thriving Youth Coalition, they have a very strong partnership with the city of Aurora and the Aurora Youth Violence Prevention Program. We also have the Tri-County Overdose Prevention Partnership, which I will speak a little bit more about. And then our syringe access services, which I hope you are all aware of, you approved it. We've been working through environmental health as well as the syringe access, working together on looking at syringe disposal efforts, how we can help people safely dispose of syringes, which protects the community, really making sure that we don't have syringes in our community. We do Narcan education and distribution when we have Narcan available to distribute, and then of course, data surveillance. So why do we do this work? We do it because it's important, and too many people are being lost to this issue. It is a component of our public health improvement plan. Goal 3 of our mental health focus area is specifically to reduce overdose deaths. So this is called out in our FIP. Also, doing this work is a component of the Colorado Core Public Health Foundational Services. So there's 2 components, probably more. If I thought about it, I could probably link it to every single one. But specifically the Chronic Disease and Injury Prevention and Behavioral Health Promotion Core Functional Service, that lines in exactly with a lot of what the CHP division does, as well as access to and linkage with healthcare. It's an important role that public health plays, helping to get people into treatment. We also have multiple funding streams that support this work. There is no one overdose prevention program. This is multiple funding streams and multiple programs across the agency coming together. So we have state and federal grants that support the youth substance use prevention coalitions. The syringe access program is funded through state grants. We do have some general funds that support a little bit of staff time, and which is primarily used for TCOP. And then also we have both general funds and a state grant that support our epidemiology staff. So a little bit about TCOP. We are a community-based partnership of public and private partners, and I'm a big believer, and I will continually repeat, we're a community-based partnership. The health department does not own this partnership. We merely provide staff support. This really needs to be owned by the partners. I didn't even want them to put Tri-County in the name, but the partners came up with the name because I don't want it to look like it's our effort. We really do want to support the partners. Our mission is to work collaboratively with local communities impacted by drug overdoses through effective prevention and treatment strategies. We have a range of sectors at the table. We do want to grow our membership and active participation. We know, and we've seen over the years, we have seen some of that active participation dwindle a little bit. And just because we know that everybody has so many other priorities and competing things that they're trying to address, that we have seen we need to grow that membership. We also know that we do have a lack of lived experience at the table. And that really is the key, is making sure that it's not professionals deciding for community what they need, but it's really working together in that partnership. So we do have a goal in 2022 of growing our membership, specifically by getting better representation of individuals with lived experience. COVID, can't deny that COVID has presented some challenges to many of our partners and to the partnership as a whole. But we do have some good highlights. We have not completed our 2021 annual report yet, but I can tell you that we do have kind of a new and improved web and social media presence. So please find us and like us on Facebook. We every year for 5 or 6 years now, we have done an annual International Overdose Awareness Day event that is in August of every year. And the last several years, we have had Narcan distribution. At that event, we're very grateful to our partner in Signal Behavioral Healthcare, who has been able to provide the partnership, no cost Narcan that we can then give out to individuals. And there has been a training at the event, as well as the distribution of the Narcan. In 2020, we used funding that we received that was allocated through Senate Bill 228. We used that to conduct focus groups with individuals who are in recovery. We really wanted to understand the barriers to treatment. And a lot of what we learned, we want to understand their experience in treatment and the barriers that they experienced. And what we took from that is really what the treatment work group of TCOP is trying to utilize to help guide their future work, how we can increase peer support as well as equity in the workforce. And that was a very common theme, was a lot of people kind of saying, none of the providers looked like me. I didn't feel comfortable. We heard that especially among individuals who are gender nonconforming, really felt, there was no place that they felt comfortable. And so that was a lot that we learned from that project. We also, the partners came together to provide input into some strategy prioritization for the opioid litigation funding that's coming out. We did not tell anyone what to do with the money. We did not write anyone's work plan, but we did create really just a prioritization. These are all the things you could do from a public health perspective. This is what we think is high priority. This is what we think is medium priority. This is what we think is low priority. That was requested by a county commissioner in Adams County. And then we also shared it with a county commissioner in Arapahoe County. Once she learned that we had done it, she asked for it. And we are happy to continue sharing that. And whatever else the counties need from us, we are there to help them really kind of provide that guidance. And from a public health perspective, this is what the community needs. This was TCOP's 2021 strategic plan that is going to be extended into 2022. I think we were a little, we reached for the stars, right? Because if you reach too low, you'll always, you don't feel like you've accomplished much. So we really wanted to try to achieve a lot, and we are going to continue this into 2022. We have made good progress around public awareness and improvements on the website and the Facebook presence, and then we are going to continue to focus on growing our partnership. We did create a new data and evaluation work group. We are continuing to look at how we can promote more policy. And then the treatment work group has hit a few barriers just due to partner capacity. We have many committed partners, but just being able to get a lot achieved. But these are the ideas that they came up with based on what we learned in our focus groups. And then we're also very focused on how we can really have that focus on equity and eliminating systemic injustices across all of our strategies. We also have the syringe access services, and I'm hoping a lot of this is review because I stole a lot of these slides from Lauren, who presented to you in September. But I just want to make sure that I do include this work. It's very important work related to overdose prevention and overdose treatment and harm reduction. Not, if you're not ready, you're not ready, and we need to make sure that we're keeping people safe. So while we often hear about syringe access really being about disease control and prevention, which it is, it also really has a lot of impact. They do provide fentanyl test strips as well as naloxone to their participants. So in just the 10 months of January through October 2021, this program distributed 900 fentanyl test strips, and 339 individuals were trained in and provided naloxone. They also, in the range of everything that they do provide linkage to substance use treatment as well as mental health services. And they, especially the staff who do the outreach, they really are a trusted person among participants who are able to, who are trusted when they're providing the referrals, which does help once people are ready to be able to get them into treatment, as well as a range of wraparound services that get people enrolled in Medicaid, focused on housing, which we know are important factors to helping people in their recovery. These are some of their data. This has not changed since what Lauren presented to you in September, but we are seeing a large number of participants, and we've really seen it grow. We have 200 enrolled individuals. This is, for just half a year, 120. So that's looking to, these are continuing to grow. Syringes dispensed and syringes returned. We have a very high return rate, which my understanding is that many programs don't have as high of a syringe return rate. So also thinking the environmental impact that we're having is very strong. And then, this is an underestimate, this number here of just in the half a year, 12 self-reported reversals from Narcan. That's self-reported. That is just the person came back and asked for more and said it's because they used it. So I believe that is underestimated. And remember, each one of these is a person. A person can't recover if they're not given an opportunity to recover from this overdose and then recover from the substance use disorder. So it's so important to think that these are actual people whose lives were saved. We also provide community naloxone training in the community. In 2020, the number was pretty low because of COVID. We were still learning and kind of navigating what kind of community outreach we were doing. So not as many individuals reached, but in 2021, this is again through the end of October, 204 individuals were trained. And this is this isn't even the TCOP work. This is just through syringe access. At a variety of settings, we have built a lot of relationships with motel employees who unfortunately have experienced overdoses in their motels and have been coming to us asking to have Narcan at their desk, as well as many community organizations and concerned family and friend. And if Narcan is one of those things, you can't hurt someone if it's not an opioid overdose, it won't hurt the person. So Narcan is that thing that everyone should just always have, because you never know when you might need to use it. So just looking ahead, some of the goals for our agency, we really are looking at restructuring TCOP, the meeting schedules and the work groups, trying to figure out how we can get some more active participation and really accommodating partner schedules and priorities, growing the membership, and really, again, thinking about that better integration of equity efforts. We have applied, I have here the NACCHO mentorship program. We have applied for a program through NACCHO, the National Association of County and City Health Officials, as a mentee in equity efforts specific to overdose prevention. So how we can increase our work related, specifically our overdose work, how we can better integrate equity. And I am super excited about the opportunity to participate in something like that. We have talked about our, needing to do that with our public awareness work, even our data work. How are we better utilizing data for equity? So that I think will be a very exciting thing coming up. As I mentioned, we will continue to extend the 2021 action plan into 2022 to be able to have more time to accomplish everything that we set out to do, and really focusing on that treatment access work, which again was a focus and a goal, and our partners are still committed, but we had really lowered capacity due to staff turnover and other things at some of our partners as well. We are happy to continue participating with counties and others as requested in discussions related to the opioid litigation funds. We just want to see good work happen in our communities, and we are happy that there is some funding coming in, and any way that we can contribute to that, we are happy to do. There are plans to start more mobile syringe access service outreach work across Arapahoe County, and then also increasing the syringe disposal box locations and how we can improve syringe disposal opportunities in the communities. So in May 2021, a community disposal box was installed outside of the Martin Luther King Library in Aurora, and that was a partnership that we had with the city. And then we have also submitted an application to have one installed at the Tri-County Health Department Englewood office. So we are really excited to be able to have that one done, and then to really expand in our communities. We are hearing from our communities that this is something that they want. There's also a goal of opening a Syringe Access site, a fixed site in Adams County. Currently, our only fixed site is in Aurora. So that was my quick overview. I'm happy to answer questions. And then if you do have further thoughts, feel free to reach out to me. I am the CHP manager overseeing the bulk of our youth prevention work, as well as the TCOP work. And then Lauren, who is the manager over Syringe Access. And I do just want to make sure I give a shout out to all of the team members, because it truly is a team effort to be able to do this work. And this probably isn't even all of them. And I will publicly apologize now to any team members whose names are not on here.
Thank you, Maura. Jan, did you have a question?
I did. Hi, Maura. Quick question. I know that your TCOP membership, some of them are physicians, some of them are physicians in rural areas, ERs, or EDs, they call them now. What kind of, are you looking specifically, when you say you want to expand the membership, what kinds of people, are you looking just to involve more of these type of people or organizations? Or I was just curious as to what kind of organizations you'd be looking to add to that.
That's a great question. And off the top of my head, I do not know kind of, if you broke it down by sector, kind of what proportion of what sector is at the table. We are looking really for, we want to make sure that we have, even if they can't come and be active, that we have access to everybody. For example, I will give a shout out to the Genoa Pharmacy, who partners with a lot of the community mental health centers. Their key pharmacist basically said, look, I can't come to meetings, but I'm here. And if you need anything, and we have gone to him just to say, look, I need a pharmacy check-in or things like that. So, we do want to make sure that we have specialties available as we need for expertise. But we mostly are looking for community members who want to be involved, as well as really, we'd love to increase our involvement among individuals with lived experience. We are trying to get away from that old school, I'm public health, I'm going to tell you what you need. We really want more people involved who can tell us really what the experience is and what they need.
Great.
Thank you.
Thank you, Julie Malika.
Yeah, quick question. So when you say you guys do community trainings and pass out in the lock zone, what does that training look like? Is it typically in person, and just how long is it, out of curiosity?
So I think we can do either. I think we can do in person or virtual. And I know a lot of them switched to virtual. And I am pretty sure, maybe Penny can correct me, I'm pretty sure that we also have staff who can do that training in Spanish. It's not long. I think it can be maybe 30 minutes, but it really is kind of recognizing the signs of an overdose, how to use the Narcan. The Narcan itself is very simple. It's literally you put it in someone's nose and you push the button. But it's really kind of explaining how to recognize the signs of an overdose, how to do, I don't think they talk about CPR, like I don't think they teach CPR, but they talk about the importance of check the person, call 911, do CPR. So it is not super long or involved, and there's a lot of staff who can do it, and we also have other partners who can do it. If our team is not available, we can have others.
Okay, well, because I was just thinking, like the opportunity to really just connect to so many different communities is if it's as simple, if it's even online, that's even great, and especially if there is opportunities to distribute naloxone to the community, that would be just so great. And because, I think more and more communities are realizing, if not face-to-face, with the increase of these deaths. And I mean, my community was impacted just a month ago. Really, there was a young woman who was found behind Safeway. And so, that it breaks the community's heart when this happens. And a lot of community members reach out and ask what they could do. And so I think definitely working with local governments to even put together work groups or advertise training or, just even talk about it, to be honest with you. I feel like a lot of people are experiencing these deaths personally. They're experiencing in their families or friends, and a lot of people just want to know what they could do. And even if this training is something that could help, especially with the youth prevention, I think that, our youth councils would be a fantastic group of folks who are already invested in bettering their community, working with the school districts, to also spread that message. There is so much, I think, pent-up demand and need for more information. And, it's fabulous that we have folks like you and the TCOP to really address, these community needs. So thank you for presenting. I really appreciate all of this information, and, just keep doing the work that you're doing, and keep spreading that message, because there's a huge need in the community.
Thank you. Julie Shills?
Oh, if I can just really quickly say, there may be I believe there is an online as well that people can get access to, because I'll double check with Haley, but I'm pretty sure when we do distribution, if we're not able to do a training at the time, there's a brochure that goes with it that says, these are the 1, 2, 3 steps, and here's the website to go to as well. It's not necessarily the kind of, again, it's great to have that training, but it's not the kind of thing that's dangerous to give out without having someone go through training. You don't need to be certified. But I do think there is that online thing as well. So thank you for that.
Great. Thank you, Julie Shills.
Yes, I just wanted to echo, thank you for the presentation, and it is critical work. The data that you provided initially highlights how important the work is. And I wanted to also acknowledge that I appreciate that you're looking at the lens of health equity and how to think about that more fully, bringing in people with lived experience, being a part of national programs that maybe can, support the team in your efforts. And I just wanted, shout out to all the work that you're doing, but also we'll be very anxious as we head into 2022 to hear about your success in that, and continued efforts in focusing on all of the work of the overall program, with health equity being infused through every component. So thank you.
Great. Thank you. Dr. Douglas?
Yeah, Mara, thank you. And I want to thank our board members for suggesting the topic. It's a critically important one, and it's wonderful for us to be able to share what we're doing with the board. 2 things. One is Mara, the provisional data for 2021, I believe, are probably through the 3rd quarter, into the 3rd quarter.
Likely, but I don't know that I was given the final number.
Yeah, I think so. I just want everybody to take that potential downturn in Arapahoe County in 21 with a grain of salt. Mm-hmm. Maybe missing 25% of the year. Secondly, Mara, I know we're probably a little over time, and we don't have any definitive understanding yet about the various opiate lawsuits and how the settlements will play out and this kind of thing. But could you offer any sort of preliminary conjecturing about any sort of support that this program might at least be interested in receiving? I think it's so fantastic to see what you've done, but every time I hear you talk about it, I go, gosh, how do we scale this further? To me, scaling is the issue here. And any quick thoughts about that?
Of course, you're going to make me say this in a public meeting. I am famous for saying, I don't want your money. I just want good things to happen in the community. But if you were to share money with us, we could use more staff focused on this. We know we could. We are grateful that we received general funds from our counties that we are putting towards this, and it does cover some staff time, but that number has held steady while staff salaries have gone up and other priorities have happened to where we can't cover as much staff time with those funds. And so we know that we could do so much more with TCOP if we were able to have additional funding to support more staff, as well as funding for, right now we can't fund any interventions. Anything TCOP wants to do, it's got to be we're coming together and who can contribute, which is a beautiful component of partnership, but it also does kind of hinder our ability to do large scale interventions. So, if a government entity, we're looking to share any of those funds. TCOP would put it to good use to really live out this strategic plan, as well as to grow the work that we're able to do, grow the partnership, and have more kind of that lasting impact. Syringe disposal takes money. We have staff who are qualified and able to do that. If a community wanted that done, we have staff who are able to do that. We actually had a staff person in 2020 really he completed a kind of a study of syringe disposal needs in the community, what it would cost, who is interested, and we understand all the barriers to communities. Yeah, we can host it, but I can't provide the staff to do this or that, or paying to empty it. So some regular funding there that we would be able to put that towards syringe disposal if that were a component of interest. And then Syringe Access is well funded for what they do. They would also be able to expand with additional funds as well. So I think we could put some additional funding to good use.
Thank you. Jan?
Yes, it's my understanding correct that the money that would be coming from that opioid lawsuit will be sort of divvied out by the state primarily, or the first people, and then it goes from there to wherever, and that it isn't going to be handed to Tri-County like a lot of people might have thought.
Correct. So the way there's going to be 4 pots of money, the smallest of which will be held onto by the state for statewide effort. The next smallest will be another statewide, they're calling it a statewide infrastructure pot for communities, especially rural communities that really need to build up their infrastructure for treatment and other things. And then 80%, maybe 75 or 80% will go to locals. I want to say 60% is going into what they call regional pots, and each of our counties will be their own region. And then it's, I think 15 or 20% is going directly to local communities. So Adams County will receive its own allocation. The city of Thornton will receive its own allocation, the city of North Glen. So Tri-County, you are correct, will not receive any of that funding, but we do work very closely with our counties. We are the health department for those counties, and we do provide those services and have been consulted. I think one thing that people aren't really factoring in is that it sounds like a big number. It's, I don't know, 100, it's a big number until you break it down into all of those pots and all of the local communities. And it really ends up being a small amount of money per year over 18 years. So smaller communities could, potentially only be receiving $100,000. I'm just making that number up, but it is pretty small. And Councilwoman Mullica, I don't know if you know more about kind of from the local government angle.
Thank you.
Yeah, as for what I know we were briefed on just kind of that same distribution that you just outlined. And I know that each county is moving forward with forming their own group. Very similar to how we have conversations about other regional issues like transportation and things like that, with the group coming together and a representative from each city to decide how to move forward. As for the individual cities themselves, we haven't had any further conversations about how that money is going to be moving. But, I'm assuming that Adams County group, at least because I'm in Adams County, is really going to be pivotal to deciding how money throughout the region, even the city-specific money, is probably going to be spent and who gets it.
Yeah, and the regions as well, there's an oversight committee that is kind of set up in the agreement who must be on that oversight committee. And each region is required to have a representative from their public health department. So, whether that's Dr. Douglas or somebody else, Tri-County Health Department will have a seat at that kind of that regional oversight committee.
Great. Maura, do you have a sense of when that money will start flowing down to our area?
I wish I knew. Every time I ask Heidi, there's still no update. I know there have been 1 or 2 settlements that have already come through. And again, Julie, you might know more. There've been a few settlements that have already come through, but it was so small, they were waiting for more pots to come till it was a larger pot to distribute. So I don't know if Dr. Douglas or Julie or anybody else has heard anything new that I haven't.
I haven't heard of a new date at all, but I'll ask Heidi next time I see her.
Great, thank you. Not seeing any more questions. Thank you, Maura, for that wonderful and very thorough presentation.
Absolutely. Thank you, guys.
Yeah, thanks again. So we are running behind time, but we are now ready for Dr. Douglas's COVID-19 update. Thank you. Take it away.
Yeah, thank you, Kaya. I did send the slides out last night. They were draft. There were a few confusing issues. They've been modified. So I will try to catch up for the time and as I go through these fairly quickly. Next slide, please, Renee. I do want to cover, it looks like a lot of topics, trends, vaccinations, Omicron, the mask mandates ever in the public's eye. A couple of quick words about new options in treatment and sort of like, where do we go from here each month? Next slide, please. So let's start with the case curves. Left side is Tri-County, right side is the state. The curves look the same. Our trends have really been quite similar. I think the question is what's happening on the rightmost part of the curves. The state doesn't show that gray zone that we do that says these data are a little imprecise. We do seem to be clearly having had since early November, even pre-Thanksgiving, a decline in cases. I think the question as to whether that little thumb on the right side, particularly notable in the state data, is a real thumb, or whether it was a post-Thanksgiving catch-up. I think we do know that during the Thanksgiving, which is now like almost become a week of, traveling and whatnot, there's less testing happening. I mean, we saw, for example, testing dropped during the week of Thanksgiving by 40% in Adams County and about 30% in Arapahoe County. People, sniffles, maybe they don't want to bother to go get tested. We saw test results that actually got done being delayed. We saw data about hospitalizations being delayed. So I think we're getting pretty close to being out of the post-Thanksgiving data obscuring. And we'll again have to see whether or not we took a hit during the Thanksgiving holidays. Next slide, please. This is our mapping, just to give you some sense. As a reminder, red is the color coding CDC uses for high levels of transmission. And I just want to show you by census tracts that we do have, and greater than 100 is a high level of transmission. It's pretty high. We're still showing you Douglas County, but if you just focus on Adams and Arapahoe, it's pretty high in most parts of all three counties. We had a conversation with some of our superintendents in our schools on the plains, and they were confused by test positivity numbers and case rate numbers. But if you look at those big census tracts in Eastern Adams and Eastern Arapahoe County, they're actually not the very highest. There's some a little more westward that have as high or even higher rates, but they're really among the highest. So we do see cases of a pretty high nature pretty much dispersed throughout the counties. Last week, when the School of Public Health modeling team estimated how many of us are infectious now, they've provide that data periodically. They haven't given it to us at the county level, but it's about 1 in 70 right now. So obviously that's not an average spread across the population, but just to give you some sense as to what's happening with current case rates, which we know, by the way, don't diagnose everybody. But it is a flavor of what we do know based on those that are diagnosed. Next slide, please. These are data looking at rates by age group, and I've really, and these are just Adams on the left and Arapahoe on the right. And I wanted to show these to you because this gives you a flavor that the orange group, that's the 6 to 11-year-olds who now about a month ago became eligible for vaccination. And we're seeing more and more vaccination in that age group, which is fantastic. But they are the least well covered of any vaccine eligible group. They have been having the highest rates throughout the school year. That's where we've been seeing the outbreaks throughout the school year. I do think we've begun to see that drop, just like those overall rates during the middle part of November. And again, you see the thumb there. And I don't know if the thumb is a post-Thanksgiving data catch-up blip or if it may represent, we're obviously going to be having colder weather now. Maybe it'll actually snow tonight, whether it will begin to reflect some of the seasonality that plagued us last year. Next slide, please. Let's turn to hospitals, because hospitals was a big focus of our discussion when we did pass our indoor mask mandate a couple of weeks ago. Left is Colorado, right is Tri-County. And we are seeing a decline that I think is probably a real decline since, again, the early November timeframe. Now, there's not yet a thumb there, and there's not a thumb in our counties either. Adams has been the highest, with Arapahoe and Douglas pretty similar. They've all gotten, by the way, very close to, or in Adams's case, above the 2 hospitalizations per 100,000 rate that we used last spring as our metric for whether to extend the dial or reimpose the dial. And they're not as high as they were last December, which was the benchmark for the worst time of the pandemic thus far. But you can tell they're fairly high. And I certainly hope that downward curve continues. Again, as it gets colder and as we continue in a time of year with the holidays when we do gather more together, we'll have to see what that looks like. Next slide, please. There we go. So that's new admissions to the hospital. This is people currently in the hospital. And here the decline is a little less brisk than new admissions. These are COVID patients in the hospital. Tan is people still awaiting diagnosis who probably do have COVID. The blue stuff is people that have had confirmed COVID. Again, maybe a little bit of a thumb there. And again, not higher than we saw last December, but certainly quite high. And the available beds that we have in our hospitals now compared to last year, because of this ongoing crisis in staffing availability, means that the margin of error, the margin of how many staffed beds are still available, remains a big challenge. We, of course, talked about that in detail when we passed the mask mandate, and that remains a continued now, close to 2 weeks later, a major concern. Next slide, please. This is looking at Tri-County data, and this is a slightly different in the graph at the top way of thinking about the hospital situation. It's the proportion of all hospital beds occupied by COVID patients. And a couple points to be made here. Number one, we're not as high as we were last December when we got to 18%. We're pretty high. We're about 14% right now. Now, on the one hand, 14%, you could say that's not all that many people. That doesn't seem like a lot of margin for the mask mandate or other measures in the community to really make a difference in. But remember, this is on top of all the stuff that used to happen, car accidents, appendicitis, et cetera, plus all the delayed care stuff. And if we're going to make an inroad in the hospitalization problem, this is really the most preventable fraction that we probably have to take advantage of. The bottom table is one that's on our website. It's in Adams' report every week, and it just shows you maybe the first column's the most important. Beds are still tight. No free ICU beds in Arapahoe or Douglas, just under 5% in Adams. Dr. Faywell.
John, how many of those are occupied by people from Adams County, from Arapahoe County, and how many are from outside of the 2 counties?
We've never been able to get that data. The hospitals won't share it. We have reason to believe, based on the proportionality of rates of hospitalization in the metro area versus some of the more sparsely populated parts of the state, that an important fraction is probably not from those counties, but we've never been able to identify that fraction, nor the fraction that may be coming from the surrounding states, because we do know that Colorado really is a receiving area, frankly, not just for Wyoming or Idaho, but Kansas and last summer, for example, when Texas was bad, even Texas. So it's a hugely important number that we've never been able to get.
And yet Adams and Arapahoe go under, along with the rest of the Denver metro area, under restrictions for possibly the problems from other locales, which aren't under any restrictions.
This is a huge issue, Dr. Faywell. This is why we have believed that if one is going to do anything to try to deal with the crisis of hospital capacity, statewide action is the name of the game. I will say that And I didn't want to do local action because of all the headaches and inequities it would lead to based on that very point. I will tell you that the vast majority of patients being hospitalized, even though proportionately our rates aren't as high as in other parts of the state, are in fact from the metro counties. Arapahoe, I've got a slide I'll show you in just a second, has got the second highest number of hospitalizations. So if we're dealing with a resource that could affect not only people with COVID, but a person with a heart attack or a car wreck who lives in our counties, it would be much better if preventive measures were being done broadly. But I felt like, and still do really, that preventive measures being done locally is better than nothing. So
Thank you.
next slide, please, Renee. Really good question though, Tom, thank you. This is looking at the regional bed capacity. We look at the region because exactly from Tom's point, people don't get hospitalized just in the county in which they live. They tend to be hospitalized across a broader region. And we felt like it made sense to look at it at that level. We're actually up a little bit. 2 days ago when these slides were made, the ICU capacity you could see was quite low, 3%. Non-ICU capacity was 4%. ICU capacity is up to, I think, 5 or 6% today. It has fluctuated. And so I don't want to, say, eureka, this is proof that, things are working, because it could turn the next day. But it's quite low, and maybe we're seeing signs that it might be getting better. But lots of concerning territory ahead of us. Next slide, please. Vaccination, the bright note, that's the bad stuff. Here's the good stuff. And the good stuff is that the Adams in blue and Arapahoe in orange, we continue to see higher and higher rates of completed vaccination, 74 and 75% respectively. We really have almost narrowed the gap with Douglas County, which was about 15% difference at one point. Still not as well vaccinated as Denver, Broomfield, and Boulder, but certainly getting higher. And we now on our website, you're probably aware of this, monitoring the additional booster rate. These are adjusted for those that are eligible. So currently we're talking 33 and 38% respectively. This is not a luxury anymore. Omicron, as I'm sure you're hearing in the news, has made the booster an absolute necessity. Data that's come out from Pfizer and a few other laboratories, South Africa, I think Germany, over the last couple of days have made pretty clear that post 2 doses of a Pfizer or Moderna vaccine, your protection against Omicron is substantially reduced in terms of neutralizing antibody titers, which is the proxy immunologic value we use. After the 3rd dose, you get much, much higher. And so it looks like that 3rd dose, again, is not just an extra boost to the gas tank. It's really essential if Omicron begins to spread. Next slide, please. This is, again, a slide I show you guys every time. It's looking at vaccines by age group. I'm really pleased to see our 5 to 11-year-olds coming along. Focus initially on the initially vaccinated, 18% in Adams and 26% in Arapahoe. Obviously, we don't like seeing Adams lag. That's been the story since the beginning. Just now are the kids being able to get that 2nd dose, 6 and 9% respectively. This is really, really a critical population that we want to be reaching. And it's a population that parents are still being really thoughtful and in some cases somewhat cautious about making that decision. We understand that. And we're looking for every way we can of helping parents feel comfortable making that decision. We're doing substantially better in the older age groups, although again, in our 12 to 15 and our 16 to 17-year-olds, we're still less than 70%. And then I'll refer you to the bottom column there, or row rather, our 70-plus-year-olds. Those are very full glasses, 87 and 91% completed vaccinations in Adams and Arapahoe, but it's the part of the glass that's empty. This is the group that is at greatest risk. And when we talk about the fact that the hospitalized COVID patients are 82% as of yesterday in Colorado, for example, unvaccinated, this and the 60 to 69-year-old groups who you see have got bigger parts of the glass that hasn't been full are what really I think creates our primary concern. Next slide, please. This is a slide that Dr. Hurley showed, and it got picked up by the media because it's really impressive. It shows the age-adjusted risk of being hospitalized with COVID. And now it's comparing for the first time unvaccinated to, quote, fully vaccinated to boosted people. And I think the big news here was that people who've received boosters are over 3 times less likely to be hospitalized with COVID compared to vaccinated people, not compared to unvaccinated people, but compared to unboosted people. So that booster, even, and this is really pre-Omicron because we don't have a lot of Omicron yet, knock on wood. This is Delta, and that booster, even with Delta, is giving you a substantial additional advantage. And then the booster compared to unvaccinated people, this is the number that hit the headlines, almost 50 times less likely to be hospitalized than unvaccinated people. So we're going to be, we don't yet have the ability to run the numbers like this, although the state's developing the algorithm that I think will give us data that we can look at this in our counties as well. Next slide, please. I show you guys this, and I just want to say this is Adams and the next is Arapahoe, that we continue when one looks at our populations by race ethnicity to see gaps ever so slightly closing between our Hispanic residents in green, our African-American residents in orange, and our white residents that have been sort of the reference group in tan color. And that bottom line, we've been showing you guys this, shows you what that rate ratio looks like. It's getting gradually better, but it's really mostly stuck. It's about 1.7 times higher in whites than in Hispanics. Again, I'll remind you that we do think we have a lot of missing race ethnicity data that may be obscuring just how bad that disparity actually is. It may not be quite as bad as it looks. Medicaid's coming to the same conclusion. I just saw a presentation of their data today. They see disparities and they see a lot of missing data in groups that they think may be more commonly occurring in communities of color, but no question. And as we get into the booster game, now a vital part of the game, we're going to start this all over again. Hopefully those that made the choice to get the first course aren't going to need as much time or persuasion to get the second course, but I don't think we can take that for granted. And we're really going to have to keep these disparities in mind. Next slide, please. And this is Arapahoe County, and I'll just say, hey, it looks pretty much the same. And the answer is it's very, very similar in terms of the disparities that we're seeing. Next slide, please. Tracy Anselmo has done a fantastic job leading our vaccine partnership team with the community. Tracy's been working diligently really since May to focus on a number of our quote unquote higher priority neighborhoods. These were neighborhoods that were initially lagging in terms of initial doses. Again, we focused on parts of Aurora and Adams and Arapahoe, Commerce City, Federal Heights, Sheridan, Inglewood, Thornton, North Glen. And honestly, when you compare it to the lines for the counties, Adams blue, Arapahoe orange, we're seeing progress, but the gap's not really closing. These are challenging areas in which to get our residents interested and able and accessible to receive vaccines. I do want to say these remain high priority areas, just like Maura talked about using mapping for opiate outreach work. We're certainly doing the same for vaccinations. And again, things are improving, but we'd obviously like to see them improving faster. Next slide, please. And so across the districts, our big priorities remain equity, equity, equity. We are coordinating very avidly with CDPHE on boosters and the 5 to 11 rollout effort. We continue to try to incrementally expand our relationships with community-based organizations working in our priority neighborhoods. Again, our priority populations are trying to get these 5 to 7-year-olds vaccinated. We're working directly with nearly all our school districts in the jurisdiction with education and vaccine clinics. Again, this is gradually getting better. The other end of the age spectrum is the older folks, particularly those that are super at risk because they live in long-term care facilities or they live in isolated settings. We're working very closely with Jogan Health to help get these groups vaccinated. I mean, everybody's a priority, don't get me wrong, but these are the groups that we think may either have the most to lose, those in the long-term care facilities, or the most to gain, because they've just now gotten access to the vaccines, the younger kids, and we really want to be focusing on those. Next slide, please. These are not our data, but they're interesting. Tracy shared this with me from the State Health Department the other day. They're tracking on what we know about boosting in staff and residents of long-term care facilities statewide. So we've done pretty well. That glass for residents and staff is more than 90% full. I wish it was 100%, but it's good. And the staff, as you can see, made substantial catch up from the middle of the summer through the more recent time period after requirements for vaccination went into effect. The challenge now is the booster front, the new front, the third wave, the third dose. And here, the slope is really good. It's steep, but we still got almost half the residents who absolutely need a booster tomorrow, not yet boosted, and an even lower fraction of staff that have been boosted, and a higher fraction who need a booster. Next slide, please. So let's turn to Omicron, and this is almost like peer-to-peer conversation, because everything I know I'm reading in the papers and you're reading it as well. But just a level set, Omicron, which is genetically speaking B11529, but we're just going to call it Omicron. It's apparently one of the most mispronounced words over the last 3 weeks. And I'm told that there are many officially correct pronunciations, but the American approach is Omicron. I think the Brits are Omicron. So again, it first was detected in South Africa. They've got fantastic genetic surveillance and sequencing capacity. It may not have originated there. We just don't know where it originated, because the slide on the right, or the panel on the right, shows you in an impossible to read dendrogram, a genetic tree. And the green blurry stuff at the top are all the Delta variants. They're more newly evolved. Omicron evolved from what appears to be earlier lineages of COVID. It actually is closer to the Wuhan strain, the original one, than it is to either Alpha, the one in UK, or Delta. What was really striking about Omicron, just to remind you, was that when the South Africans sequenced it, it had an enormous number of mutations. It had 30 mutations on the spike protein and another 20 scattered around. And even if we didn't have any epi data, we would look at that genetically and go, oh, wow, that looks like a killer. That looks like it could do all kinds of bad things in terms of transmission or immune evasion. Next slide, please. The left panel here is a slide Dr. Hurley shared from South Africa. It's about 10 days out of date, and it's moving fast. What I really want you to focus on, Gauteng is the province in South Africa where Pretoria and Joburg are, Johannesburg. And that little red thumb on the right is what alarmed the South Africans. So when they saw that little red thumb on the right, which was a pretty steep increase, the actual slope of that increase was even greater than that much bigger spike you see about 6 months ago. Coupled with those host of mutations went alarm bell, alarm bell. And that's when WHO looked at these data and the sequencing and said, this thing is going to be declared a variant of concern in record time, 48 hours after the South Africans notified them of it. And around the same time, the South Africans have pulled together data about what has predominated in terms of variants in the South African setting. We did never have much data in this country, but that was the big story in South Africa for quite a while. Very quickly replaced by Delta when it came. And you can see that very recently, Omicron, which is that little blue sliver on the right side, is now making a significant inroad in what's happening in terms of distribution of variants in South Africa. Excuse me. The New York Times has an article this afternoon about what's happening in Britain, who actually has the best genetic sequencing capacity in the world. The current estimates are that Omicron is doubling twice a week in Britain. And the expectation is that Omicron, if that rate of increase continues, will comprise 50% of British variants within the next 3 weeks. So we now have two countries, this one South Africa, the other one Britain, where it appears that, especially in Britain, a very heavily vaccinated population, 70% primary vaccination, and I think about 40% boosted, the variant can move quite rapidly. Next slide, please. The first Colorado isolate, I think you're probably aware, was identified by our team in Arapahoe County resident. But of course, it was frankly just coincidence that we happened to detect the first one because it's spreading, we think, quite rapidly across the country. What we know about it is what I've just said. Many mutations, they concern us. Rapid spread in South Africa, add to that Britain. What is not known, or at least not completely known, are the key biologic factors. How transmissible, how severe, what are the vaccines going to do? What is prior infection going to do? Is it going to protect you? How are our treatments going to perform? Now, since I made up this slide 2 days ago, we've gotten better data that says this probably is more transmissible. The British data are a big confirmer of that. I didn't think we were going to see a variant more transmissible than Delta, because Delta is more transmissible from an R0 value. That's that value that tells you on average how many infected people does one person infect. The most infectious respiratory virus we generally encounter is measles, and Delta is way up there just behind chickenpox and actually close to measles. Omicron looks like it's probably going to be higher than Delta. Severity. Early returns out of South Africa said maybe it's not as bad. Maybe the hospitalization rates, the need for oxygen, this kind of thing is not as bad as Delta. That's probably the most promising early return we've heard. South Africa has a much younger population on average than we do or the Brits do. And so it may be it's potentially an age-adjusted artifact. So we just have to be a little careful about taking that observation to the bank yet. The vaccination story, as I mentioned earlier, is starting to get fleshed out again. Important studies coming out in the last 2 days that suggest that 2 doses provide quite marginal protection. A third dose gives you extra benefit. The CEO of Pfizer or BioNTech, I think, said today, at least based on their review of the data, they think it's pretty likely we're going to be needing an Omicron variant, an Omicron booster within the next 3 to 4 months or so. They and Moderna, because those RNA platforms are so flexible, they can shift on a dime and really develop new approaches, are both working on Omicron boosters. Data about a week ago out of South Africa said prior infections look like they don't protect. There's been a debate. Are they as good as vaccines? How long do they last? At least for Omicron, actually pretty similar to Beta earlier. It looks like prior infections don't provide a lot of protection. And then finally, open question as to how the monoclonal antibodies, which bind to the spike protein that has all those mutations in it, are going to work. We do think some of the newer therapies may be less impacted by that, but this is the Wild West in terms of what's really going to happen at this point. In terms of guesswork, we just don't know. Next slide, please. I did want to mention the new therapies, and this is a graphic that has been put together to sort of describe the course of COVID and when various interventions might matter. And circled at the top is where we think we can best use hospitalization preventing treatment. That's where we use monoclonal antibody. You can't be on oxygen. You have to have mild symptoms. That's where we're going to use the 2 new drugs, molnupiravir, which was approved by an FDA advisory committee, or rather recommended by an FDA advisory committee about a week ago. The returns on that one are beginning to look a little less impressive, like maybe only about 35% reduction in hospitalization. Not bad, but apparently the drug has got some potential toxicity. Many of the original trial recipients avoided including people, for example, with underlying kidney and liver disease, who may be the kind of people who could get drug toxicity. The Paxlovid drug, which is the PF blah, 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 down below is a dual combination drug. It's a drug that inhibits the protease enzyme that the coronavirus, like other RNA viruses, use. And ritonavir is an HIV medication that's also a protease inhibitor that actually is often used in combination HIV therapies. And in this setting, these 2 drugs working together appear to reduce hospitalization by about 70 to 80%. A big caveat for these drugs is they need to be given within 5 days of onset of symptoms. Retrospectively, it looks like the average person is being tested within about 2 to 3 days after onset of symptoms. If test results come back in 24 hours, that means they learn they're infected within 3 to 4 days of the onset of the symptoms. That means they have 1 to 2 days to get treatment if it's going to make a difference or not. So we've been spending a lot of time among local public health directors trying to think about what sort of frame shifting in our thinking should we be doing to take, what is at the least hospitalization preventing therapy, maybe life saving therapy. What strategies are we going to have to use to get people alerted to the value of this, tested quickly, and then treated? Tom.
John, if these are going to be treatments that are done in the hospital, are these going to be like in an outpatient clinic, or do they have to be admitted? If they have to be admitted and we're running out of beds, these people won't have any place to go.
No, they're all outpatient, Tom. The infusions can be given in outpatient settings. They do require either infusions or sub-Q injections. The other ones are oral. I'm sorry, I didn't mention that vital fact. A lot of discussion about whether understanding orders pharmacists can dispense them. That's going to depend upon the toxicity profile. Can a pharmacist really, have the capacity to assess someone for possible drug adverse effects? So a promising development, but there's some caveats to it, but it is outpatient therapy.
Thank you.
Yeah. Next slide, please. Let's shift and talk for a minute about a recap on the school mask mandate situation. We've had school mask mandates since the board passed these in late August, went into effect September 1st. We've had several discussions at past meetings about potential metrics for ending the mask mandates. A tentative set of metrics we came up with our regional public health partners involved 2 parameters: case rates, 7-day COVID county case rates, less than 50. That's the CDC moderate transmission zone for 3 weeks. And one of 2 vaccination parameters, either the availability of vaccines for 3 months, that would be by February 8th, or 70% of school-age kids being vaccinated. Now, our schools are reminding us, and our own data show it, that we're a long way away from 70% of school-age kids being vaccinated. We're currently right now about 38 and 43% for Adams and Arapahoe County. We are, we'd really like to see progress made on this, but that's going to be a slow-moving metric. On the other hand, the availability metric is a time-based metric. And the map on the right is intended to show you that achieving a moderate transmission level is actually not an impossibility. It's being done in a number of counties across the country. It does appear the warmer you are, the more likely you are to achieve it. Look at the Gulf states, look at Puerto Rico, look at Hawaii, but some other areas as well. Good chunks of California, even Northern California, are seeing rates below the red. Now, our current mandate goes through the end of December. We plan to amend the public health order and replace that date with the above metrics, with one caveat. CDPHE is rumored to be considering some sort of modification to school guidance. And because many of you have pointed out to me that when we pick different metrics and for different conditions, it confuses people, and I get that. We've tried to tailor the metric to the circumstance, but I get it, that can be confusing. We don't want to officially make this change until we hear if and what CDPHE is going to do. Again, I guess I've already made the point about when we're going to get there, but I do think it's not impossible based on the experience in other places. I will note that, no surprise, masks remain controversial. No surprise when you're dealing with controversial areas, whether you're a public health director or whether you're a school superintendent. There are a lot of questions, a lot of concerns. We have regular phone calls with superintendents. We had one yesterday. They made a number of constructive suggestions. Some I think are probably not realistic. Others we're chewing on as a team, figure out whether there's any sort of accommodation we can make. Again, a lot of this may depend on if CDPHE makes any changes as well, because we're trying to obviously not be divergent from them. We've often moved when we have, because they were moving slowly, and we'll have to see what their pace and recommendations are going to be. Next slide, please. So that's the school mandate. And of course, more recently, we passed the public indoor space mask mandate. And Tom, this is the answer to the question you asked earlier, which is, excuse me, why should our counties bear the burden of this measure? And the answer is, ideally, they shouldn't. But if you look at where the hospitalizations coming from, the worst is El Paso, and they don't have a mandate, and that seems unfair. But the next four are Arapahoe, Denver, Jeffco, and Adams. And so if you're trying to sort of figure out where do you make the most bang for your buck, well, it should include El Paso, and frankly, it should include Pueblo and Weld. But you get a pretty good chunk, about 45% of state hospitalizations coming out of these four counties. And we've continued to have lower rates, but because we just have more people, we have higher absolute numbers of hospitalizations.
Are these patients with just COVID, or are they heart attack patients coming in that also has COVID?
These are patients with COVID in the hospital, and the state health department cannot do real time sorting out of, is COVID incidental or is COVID an additional condition. I will say that when they did this, took a look, obviously retrospectively, because it takes detailed chart review a couple of months ago, I think it was 90+% of the COVID positive cases were in there with what appeared to be definitely COVID compatible symptoms. Now, some do have other conditions, but the vast majority do appear to have COVID. But I don't have any real-time way of sorting that out.
Yeah, that's always a difficult question. It's like when somebody dies, they came in with a bad cardiac situation and they died. Well, they also had COVID. Did the COVID make their heart problem worse? Or were they dying from their heart condition and they just happened to have COVID and they're listed under COVID? It's a very difficult thing to sort out.
It's hugely difficult. And that's why, I mean, the retrospective studies are helpful, but they're retrospective, and what they tell us is what was true then and don't necessarily tell us what's true now. So it's a good point to make. Next slide, please. I do want to note that there's been some discussion about, this is an unenforceable order. What are you guys doing about this? As you know, we don't have an army of folks to go out and do spot checks or anything like that. We rely on complaints. These are the complaints we received so far: 126 in Arapahoe, 126 in Adams, 237 in Arapahoe. The plurality are coming in from gyms and retail establishments. And again, we try to work with these sites. We know that no business owner wants to be the mask police. We get that. We want to try to figure out if they're doing the best they can in terms of masking, in terms of staff education. We are not looking to put staff in harm's way, but we are looking to try to normalize the message about the importance of masking as much as possible. I don't have the data here, but I will tell you that we also, in that public health order, had a voluntary vaccine program whereby entities that applied to us and said, look, we can ascertain that 95+% of our staff or patrons are vaccinated, that they would be allowed not to require the use of a mask. And I think we've had approximately 75 or so. We're developing the capacity to try to put this on a website. I've had a lot of people ask me, you guys have any information about where I can go out to eat where they're requiring vaccines? That would actually affect my dining choices. It might affect my shopping choices. I mean, we've heard the opposite as well. If you're a place that requires a mask, forget it, I'm going to go to shop in Douglas County. But we are increasingly hearing people ask that opposite question. Next slide, please. This is data that I mentioned and showed you. This is an updated version of that, looking at what the School of Public Health continues to tell me is probably the best measure we have about what's happening with mask wearing in various counties. Now, this is, again, data put together by a Carnegie Mellon COVID modeling group using Facebook survey data. And they can't model every county in the country, but our counties are large enough that we can get daily estimates. And what I want you to see is that top sort of orangish line is Larimer County. And I showed you what happened in Larimer County after their mask mandate went into effect. I'm sorry, their mask mandate went into effect way back on the left side of the slide back in November. The gray part of the slide is when our mask mandate went into effect. And what you see there is Arapahoe in orange and Denver in green and Adams in blue and Jeffco in kind of brownish, compared to El Paso and Douglas in red and lighter green respectively. And at least based on the self-described, did you wear a face mask most or all of the time in public for the past 7 days? There's a clear self-described increase. For Arapahoe County, it's about 25%. And for Adams County, it's about a 21% over this initial period of time. And I think you can see that the slope, again, look at the orange and the green and the Jeffco brown, and Adams is a little flatter compared to Larimer 2 months ago. The increase in this self-described masking looks like a similar slope to what was seen there. Now, is it going to produce results? I cannot promise that. Masks are one protective device. And as Tom's already said, when you're using them in some places and not others, they're probably not going to be as effective as they might be. But I think we have a large enough critical mass of population, because Boulder and Larimer are also covered, that we've got a pretty good chance of having them make a difference. Next slide, please. This is not really related to masking, but somebody asked me the question the other day, with all the headaches that we have been going through, and that frankly, sometimes public health departments have made people go through since the pandemic began, how are we doing compared to other states anyway? I look at a map and look at Florida. They're doing great. Well, to me, one of the bottom lines is what's happened in terms of mortality. And this is a website I actually hadn't been aware of. I came across it the other day. I thought it was worth sharing, sorting out COVID deaths per 100,000 population and the COVID age adjusted deaths, because the older the population, the more the mortality is going to be. Very interesting to see that Colorado is in the top, really, I think 20% or so of states, number 39. There are only 12 states with, or 11 states with age-adjusted deaths per 100,000 less than 200. They're not all blue states, by the way. I mean, you can see Utah, you can see Alaska in there as well. But I think there's states that have done probably a better job than others. And of course, at the top, Mississippi number 1, Texas number 2, are states that, if really the bottom line is death, and again, better to adjust it by age, I think Colorado has fared quite well. Next slide, please. Wrapping up, looking ahead, we're going to continue to be cautious about the hospital capacity crunch through the holidays. We're going to continue to do the best job we can on promoting our vaccines. I think one of the groups that we've got increasing concern about better messaging to are groups of folks that are frankly a little more conservative, because national data is now telling us ever more starkly that folks with somewhat more conservative leanings are part of information networks that often have misinformation. I don't want to, that's a very gross stereotype, of course. In Douglas County, which is a conservative county, is a great exception to that. They've got quite high vaccination rates, but as a general matter, more conservative folks have had lower vaccination rates, and we're the health department for everybody, not just communities that swing one way politically or one way race, ethnicity. We want to try to get everybody taken care of. We're really going to be having to understand that value versus Omicron. We're continuing to watch. I mean, we're not talking about vaccine mandates, but we're continuing to watch how those programs play out as instructions for the future, pushing the older adults, pushing the children. Again, being attentive to the whole range of priorities or measures that may protect indoor spaces besides vaccines and masks, but good ventilation and increasingly, places that may be assuring everybody who comes there that everybody's vaccinated. We've mentioned the treatments and how we think those through and how we help get good access to them, and may have to prioritize access because we may not have enough for everybody. That'll be a challenge. I continue to list this coming to terms with the duration of the pandemic response. I'm a little cautious about using exit strategy, because exit strategy sounds like we're going off the freeway. I think we're going to be on the freeway for a while. I think what we have to do is figure out how we live on the freeway in a much less fraught and polarizing fashion. I think broader vaccination, better access to treatment. I really hope we do not ever have to do a public health order again. Many of you have told me the appetite for doing this is gone. I get it. And I think our role in playing that, we've really got to figure out what other strategies are going to look like. I think maybe even that metaphor of treating COVID like the flu is not quite right. Because honestly, I wished Omicron was the last letter in the Greek alphabet. It's actually not. But I'm afraid this is part of what we're going to see. Now, it may be that viral evolution takes you toward greater transmissibility, but less virulence, because the virus gets no payoff by killing the host. If they can infect the host over and over again, and that host can infect other people, the virus wins, evolutionarily speaking. And so I am guessing that's probably where this is going to go, but this is speculation. And then I just have to say again that we are being very attentive to the evolving nature of Tri-County. As Jennifer mentioned earlier, we're certainly being working as closely as we can with our counties, although they've got their own timeframes that they feel that they need to follow. And most importantly, our staff have always been, now more than ever, our most important tool of carrying out public health, and being attentive to their morale and our ability to carry out services really does remain one of our highest COVID response priorities. So thanks for your indulgence, your attention, and I'm happy to take any other questions if there are any.
Dr. Faywell?
Yeah, thanks, John, for the discussion and presentation, and the fact that you listed the multitude of measures that we know are effective to some degree, some more effective than others, obviously vaccination. I continue to go over the science of masking and ventilation and hand washing, etc. And although, and it's too bad we only have 6 attendees, we usually have 300, and then the word gets out. Be that as it may, even though the evidence scientifically is somewhat weak on some of these areas such as masking, that doesn't preclude a precautionary approach to the pandemic. But ethically, I think we're required to look at the strength of the evidence that we can find, and what the benefit of doing one versus the other is, and get that out to the public. I still like the the quote from the epidemiologist, I think he's on the East Coast, that I may have mentioned, where he said in areas such as ours, a metro area, not some rural place where you're the only person for 500 miles, but in an area like ours, you're either going to have a vaccination or you're going to have COVID. You're going to have one or the other. And so what's our best approach to keeping people as healthy as possible? We all know that there are problems with some vaccinations. People can have reactions. We also know what happens with people who are unvaccinated and get COVID, and they might have a comorbid problem and they wind up in the morgue. That's another result. But we have to be honest with the possibilities of each. And I think you did an excellent job of presenting that. Thank you.
Thank you very much.
Thank you for that very thorough presentation. Are there any other questions or comments? I assume, Dr. Douglas, that we'll be revisiting this at our scheduled January 13th meeting, which is the second Thursday of January. Do you think that we're going to have any additional meetings sorry, just like additional meetings to look at the indoor mask mandate or to revisit the school mask mandate? I mean, or do you think that somehow waiting until January 13th will be enough time to see trends, to see where we're going?
I think waiting till then is probably reasonable. Again, if we hit the metrics for the ending of the, I mean, we will try to figure out how to adjust the school mask mandate so it's not conflicting with CDPHE, and we got to do it before the end of the year. And we will go ahead and figure out where CDPHE is at and make that change. I don't know whether we'll get, we won't get, but the indoor public mask mandate goes through the 2nd of January, excuse me, and then until ICU capacity is greater than 10%. I don't think it's impossible. ICU capacity could be there by the 2nd, and we could, you know, be able to lift that. I wouldn't by any means count on that, but I don't think that's impossible. But I don't foresee, one of my New Year's resolutions is to ask the board to have as few special meetings as possible. So I don't foresee the likelihood of that.
All right. Well, it's a good New Year's resolution. Dr. Falo, do you have another question? You're muted.
Sorry, I forgot to lower my hand, Kaya.
Oh, okay. Okay, great. Okay, well, I'm sure we'll be continuing to discuss this. I'm not seeing any questions or comments right now. So we'll move right along to finish up the rest of the agenda. The executive director's report, Dr. Douglas, did you want to make any comments about that?
I know you guys have read it. I just want to maybe put a yellow magic marker circle around the youth violence prevention work that Heather wrote up. I think we're all aware of the just awful stuff happening with youth violence. I mean, Aurora's been in the headlines, but it's beyond Aurora. And I'm really pleased. It was great. You guys got to meet Angelia earlier today. She's a great addition to the team. She's the kind of person we want to keep recruiting to help us with problems like this. And then I just want to call out again, I think Melissa didn't write that summary of what is in some of the big federal legislation that may impact public health, but I think it's the kind of thing we want to be tracking on, because there certainly are things in the infrastructure bill that may impact us, and whatever happens with Build Back Better could impact the work we do as well. So just wanted to flag those two things.
Great. Well, you know, I was struck by all the detail on foodborne illnesses, rabies outbreaks, and instances of chemical contamination in groundwater, which really show the important work that Tri-County does, even if it is often overshadowed by COVID-related programming. So,
yeah, thank you for that exclamation point. Absolutely.
Great. Okay. Other items. Set the agenda for our January board meeting. As usual, we'll have the COVID update. We'll do a review of the current public health orders, and beyond those topics, if there are other issues that you'd like to, or items you'd like to include, please let me know. We'll be meeting presumably later on the month, and we can have further discussion about this. These meetings are open for revision and creative thinking. So let's just stay in touch in terms of what are the important issues that are emerging that you really want to discuss. Are there any board member remarks before we adjourn? Jan?
I would just like to direct my remarks to the fellow Board of Health members, Tri-County staff, Dr. Douglas, Jennifer, and the EMT. I wish you all a happy, healthy, peaceful holiday season, and to thank you all for the total dedication and hard work that you've exhibited this past year. So we appreciate it.
Great, thanks. Thank you, Jan. Any other board member remarks? I know we've been here a long time. Thank you. Thank you as always to our dedicated, unpaid Board of Health volunteers who stay committed to keeping our citizens healthy. And I wish you as well a very happy holiday season. Dr. Douglas.
You know, I'm the one that should be thanking the Board of Health, Kai. I mean, with all facetiousness about the special meetings, we could not have worked with a better group of people. You're worth, as I love to say, every penny that we pay you, and a whole lot more than that. And no, you've you've been fantastic. And as Jan said, if anybody deserves rest and peace and goodwill, it's you guys. So I just want to thank you. We're not having our traditional end of year gathering to toast each other, but I want to toast you virtually. So thank you.
Thank you. Thank you. Thank you, everybody. Okay. Do I have a motion to adjourn?
So moved.
Is there a second? All in favor, say aye. Anybody opposed? Okay, the motion carries. We will see you again soon. Let's stay in touch. Thank you all. Yeah.